Ours is the only profession where the rate of suicide is going up, but people still think we can help them, which is sad. If you look at it, there is a shortage of psychiatrists, and we have not been able to do much about the increasing rate of suicide. Well, take, for example, cannabis. People don't realize when you do cannabis, you're at a higher risk of psychosis, depression. So dual diagnosis is very common in that population.
Because I could call the sheriff anytime, and they would come, and they're also trained in mental health. So often just their presence on campus will make a difference. And they realized, oh, they're serious. I'm not going to be able to act this way or talk this way. Because all of a sudden they don't have the drug, and they realize that. And then they're having things going on where they want to just leave so that they can use and get back to that euphoria.
We talk about therapeutic neutrality and not saying something that expresses your opinion, but I don't necessarily always think it's correct. If somebody's drinking and driving and you don't tell them, you got to do something about this, you're really not fulfilling your role.
How do you stop the idea of, if I go to a psychiatrist, I'm crazy, and everyone will know? Well, good morning.
Good morning.
And welcome to the Debbie Knauss podcast. I am honored and delighted
thank you for inviting me. I appreciate that very much.
It's just such an honor to be able to be in your presence and to have someone as distinguished as you are in the field of psychiatry as a member of our podcast.
Thank you.
As a guest. So I was going to ask you to start out with, who are you? But before I do that, I'm going to ask you, who are you?
Well, I have to divide that in two portions. So who am I not? And, in this world, we get caught up in what we do rather than who we are. So I'm not a psychiatrist. I'm not a husband. I'm not a parent. I'm not a grandparent. I'm just a soul that's traveling through, and the goal is to have eternal bliss as I travel through whatever I'm traveling through and be part of God in that manner.
Wow. That made me just stop and pause and rethink about that for myself as you were sharing that very personal information about yourself. And maybe that's why we connected from the very, very beginning. But I want to talk a little bit about your credentials so people know. And Dr. Vasavada, we call you Dr. V, because not everyone can say that name.
That's right.
Is a distinguished life fellow of the American Psychiatric Association and board-certified psychiatrist. You also are an addiction medicine certified from the American Society of Addiction Medicine. You've been practicing for over 40 years.
Yes, it's been a while.
And have provided excellent service to the DFW, Dallas-Fort Worth area. Approach every patient's mental health care with the understanding that one size does not fit all. Surrounds yourself with a group of independent, superb therapists to do good work. And you're also on Dallas Magazine's Top Doctors.
Used to be.
Okay.
I haven't sought the publicity, so lately they have not ever contacted me, but it was the very first list that came out, I was on it. In fact, my name was in the actual article. There were 10 people whose names were in the article. I was one of them.
Okay.
With my great mentor, John Rush, and a few others.
And you're also a clinical associate professor of psychiatry?
Not any longer.
Okay.
I'm not affiliated with medical school.
But you were?
At one time, I was very active doing research work and teaching.
And one of the things I read about you is you see primarily depression and anxiety in your practice. Those are the two big factors. Has that changed since this article was written about you?
That's always the case. In any
Okay.
psychiatric practice, you're going to see more depressed people and anxious people. Of course, you get your share of bipolar patients, schizophrenics, and some ADD patients. And substance abuse, of course, is a significant part of my practice also. I don't shy away from seeing people who have history of substance use or are actively using to help them with the treatment. Mm-hmm. So a lot of dual diagnosis patients.
So for especially those people throughout the United States and whoever's watching this, what does it take to become a psychiatrist? Start with, you probably graduated from high school and then you have to go to college, but the years that it takes, and I'll do that math in my head.
So in the United States, you finish your high school. Most people will get a bachelor's degree. Some people go in a 7-year medical school, but majority of them get a bachelor's degree in biology or related science. And then you go to med school, and that's 4 years. And then comes the residency, that's another 4 years. And then if you do specialty, that's 2 years more. So you go through a lot of training. Things were different when I started, and it was a 3-year residency, not 4. And then the specialty was 2 years or 1 year, depending on where you went. So it takes a long time to get to that point.
So about 14 years of higher education.
Yes.
How does anyone do that?
I think you have to have compassion to do it.
Okay.
Anybody that goes in medicine for any other reason, at least in today's world, is making a mistake. They're not going to be happy. And if you have the desire to help people, then you go to medical school and you're willing to work very hard and think analytically and work with a team of people. And nowadays, the other issue is that the corporate medicine is coming, so a lot of specialists that are excellent at what they do work as employees of hospital systems or universities and other organizations.
So why did you become a psychiatrist?
That's a great story because in my class of 120, I was number 4, and I was number 3 in internal medicine. And this was back home in India.
Ah.
And I ended up getting, what we have is, first year is called housemanship, and then you get registrarship, just like they have in England, and then you take an exam. I was in the middle of my housemanship, and I was getting pretty disillusioned with what I was doing because I saw that many of these patients with so-called medical problems had behavior problems. Now, Debbie, you can take anything from patients with diabetes, patients with high blood pressure won't take their medicine, or even people working in the farms who develop anemia because there were little bugs that are sucking blood out of their body, and they come through your feet because they're bare feet. But if you try to help them and try to convince them to wear something, they won't do it. So there's so many behavioral issues that medicine has and still does. That's what attracted me to psychiatry. And it was not an easy journey because when I came here, it was easy to get residency in any field, pretty much you could get it, but my passion was psychiatry, and my friends and acquaintances were rather shocked that why would I leave internal medicine and go into psychiatry, but that's what I wanted to do, and that's what I've always done.
When did you know that? Was it when you were a little boy, or
It was in the middle of my housemanship. As I was working, I just realized that this is not what I want to do procedures. I was good at it, but I'm not interested in doing that.
So I'm curious, of the clients, patients that you have seen, and for full disclosure, Dr. Vasavada is our psychiatrist for Touchstone Ranch Recovery Center.
Yes.
And that happened because when we bought Touchstone, which was in 2014, this is year 12 of owning and operating, family owned, family operated, which I love. And I knew that we needed a psychiatrist. I had run other programs, both inside and outside of the country, and I knew that was a key component to success for the clients. And I made a list of all the psychiatrists I knew throughout the country, but primarily focused on Texas because I needed somebody in Texas. And I started just making my list. And if this one says no, then this one, and this one, and this one. And you were number one because I knew of your reputation. I knew of your success in this field. And I went with that and then asked some people that I really trusted who worked for other programs and said, do you know anyone that I should consider? And then when I came here, I started an interview with you. And it was easy, and you said yes. And it was like, yes! And I felt like I won the lottery.
Well, I felt the same way because what I liked about your program was that you are an RN, you're clinical, and you more or less run the show. In fact, when we started, you were living on the property. So if there was any problem or question, I think you were probably going home on the weekends or something, but that you were there. More importantly, you let me do what I needed to do correctly to help patients. Mm-hmm. So when you see the patient for the first time in that setting, it helps to see the patient and talk to the treatment team over the course of about an hour, rather than just letting one of your delegates see the patient. Mm-hmm. And when you do that, you get a pretty good idea and you develop a relationship with that patient that comes handy. And normally I'll see them maybe anywhere from 1 to 4 or 5 times while the patient's in treatment and help you guys direct the psychiatric part of the treatment, if you will. And thank God for the team that you have, because the physician and his team is extremely helpful. And I can always call them and talk to them if there was an issue. So whatever recommendation I make, they're willing to work with me on that. Because sometimes that becomes a problem if you're a consultant. What happens if people don't trust your judgment? Mm-hmm. But they've been exceptional in terms of working with me and asking questions or mm-hmm. questioning what I'm doing at times when appropriate. And that goes both ways.
Yes. Well, it was easy for me to identify because I have been a nurse also more than 40 years. And to know the value of physicians. And my goal was always to make their life easier, for them to want to do business with me, for them to want to take care of my patients. Because if I needed them, they knew that it was because the patient needed them. And then I could minimize the amount of time and created a protocol for our patients that needed psychiatric evaluation. Not all patients who come into a substance use disorder behavioral health facility need a psychiatrist's attention.
Majority of them don't.
And right.
But ones who do really do. Woo! Because the acuity in treatment center has gone up greatly. The boundaries between psychiatry and substance use treatment are getting more and more blurred, and we are seeing more severely affected patients. Well, take for example cannabis. People don't realize that when you do cannabis, you're at a higher risk of psychosis, depression. Your anxiety could get worse. And cognitively, you could be affected. So dual diagnosis is very common in that population. 54% of people with opioid addiction have some kind of an underlying psychiatric condition. So now it may not be a priority of treatment. And I take issue with places that don't have a psychiatrist. They have somebody that's there, a provider of some sort, who doesn't have addiction background as such. And it's kind of a learning on the job process. So often patients struggle because of that. And I see that in my practice because I consult with some of the halfway houses and places. So when I see them, the first thing you have to do is straighten out what needs to be done so that the person can succeed in their post inpatient or rehab stay in staying sober and being functional, both.
Yes. Well, and I know that together, we and the rest of our team, including our medical director and the nurse practitioners and the whole team of therapists and counselors and recovery advocates, everything, maintenance, everything that it takes to create an environment of healing, that we have taken on some really complicated cases that no one else would take on. And there was no way I could do that without exceptional staff and exceptional psychiatry and medical to follow it every single day and to be available, because it is not easy. Do you remember any, and of course we won't give their identity, but do you remember any of the really complex cases that we worked on together?
Well, I believe most of them are complex, but
Yes.
people come in and they're on one particular one that I probably will remember for a long time is somebody that came in, was on a long-acting medication, antipsychotic medication, and had severe side effects. And over the course of the stay, and that's the beauty of your program, is they're there for 90 days. So I have all the time in the world to make changes. And if something's going wrong, I got people that'll call me and say, this is not working. Mm-hmm. And the diagnosis, of course, was such that they needed something else. And we were able to successfully do that. And that person really benefited from it. And then we have had people with chronic psychosis that we have treated, treatment-resistant depression, severe depression that we were able to manage. The most challenging situation is when somebody thinks they have a diagnosis of ADHD and they want a stimulant. Mm-hmm. And most of the time, almost all of the time, the answer is no. But there are challenges with treating those patients. So I think that sometimes working with those patients and convincing them that this is not what you need, you're in a treatment center, focus on what you need to. But then there are exceptions. Recently, we had a client that I believe has a sleep disorder. And if you don't treat that, they're not going to be successful in treatment. They're going to fall asleep in the middle of sessions. So that becomes clear when somebody's off the drugs they were doing. Because now you can see 2-3 weeks later, we have some idea of what's going on. Still, the old dictum that, alcoholics wait 6 weeks before you put them on antidepressant, I don't particularly agree with that, although it has some validity. And if it's a person with drug addiction, then you can think of medication early on. But even there are exceptions. So I think that working with a group, and thank God for Dr. Turk, he's a wonderful doctor, and he's been extremely willing to work with me. And without him, I couldn't do this.
I couldn't either without both of you. And that's why we've kind of been together since the beginning. And that is one of the absolute most important components of taking clients in. I have always seen the program that if I wouldn't check in myself, or if I wouldn't check in a family member, I can't do this. That I have to create an environment where I want the care, if it was my mother, brother, sister, child, husband, no matter who it was, I would want them taken care of in the way that we take care of them. And I don't hesitate. The great thing about owning family-owned and family-operated is, yes, we absolutely have to, because we're licensed by the state of Texas at every level, which is from medical detox to residential, intensive residential, to PHP and IOP at all 4 levels. And then we're also Joint Commission accredited, which takes us to a whole new level of regulations and requirements. I mean, the manual's thick.
Oh, tell me about it, because in 1992, the regulations for JCO changed, and it was January 2nd, and they showed up at my hospital. So normally they don't even talk to the doctor, but I was told by the administration that you better take at least rest of the 2 days off. You need to be here. And they asked me questions about everything that went on. They really wanted to see that there was a medical leadership. Medicare, when they did the inspections or came for complaints, the very first thing they asked is, how many people have been transferred to emergency room from your hospital in last year or two? Now, that's sort of an interesting question. Well, there's a reason for that. They look at those charts to see if we missed something, and that led to the transfer. And in case of your facility, out of the patients I see, the only transfers we had to do is when somebody had acute psychotic break or was suicidal and needed higher level of psychiatric care. That is to be expected. But on the medical side, I mean, granted the population is younger, but people with addiction have more health issues. They're handled very well, so I don't have to worry about, somebody's blood pressure not being handled or their thyroid situation is taken care of or not, or anything of that nature.
Mm-hmm. And we have great relationships with all the support systems in Stephenville in order to take care of our patients. And if we need transport, 911 works for us. That's the way I see it. And so does the sheriff, if ever someone becomes where they could be a danger to themselves or to others. We take care of.
And that's the benefit of being in a small town, because you have relationships.
Yes.
And that doesn't happen if you don't have good relationships. And if there are signs outside on the electric posts saying don't go to this facility, then you got a real problem because you don't have good reputation and you've not protected your home base.
Yes. Because I could call the sheriff anytime and they would come, and they're also trained in mental health. So often just their presence on campus will make a difference. And they realized, oh, they're serious. I'm not going to be able to act this way or talk this way, and understand, and also let them know they have choices. If they want to stay, and usually it's a behavioral problem because all of a sudden they don't have the drug and they realize that, and then they're having things going on where they want to just leave so that they can use and get back to that euphoria, that balance. But we're there to be able to look at them and work with them. And then Tarleton State University is doing a lot of work on providing and training. They have therapists, nurses, and now an osteopathic physician program. And their whole focus is taking mental health resources out into rural communities, initially in Texas, but then to expand that. And equine therapy is a big component of what we do at Touchstone. It's one of the very simple things, but it's the medical excellence, the clinical excellence from the therapists, the recovery advocates, the spiritual part, really teaching and training people emotionally, physically, spiritually, and mentally. But there was one thing you mentioned was suicide. And most people I know, from very small town where I came from in Kansas to Stephenville to big cities, the increase has dramatically of suicide, especially in the younger population, has increased over the past few years. What do you think is contributing to that?
Before I come to that, I want to clarify that you were talking about asking for help from the law when it was believed that the particular patient is at a high risk of hurting themselves or somebody else. Treatment is voluntary, but if there is concern about suicidality or violence, we as professionals have the responsibility to get the law involved, to get a commitment to a local psychiatric facility. Now, I joke about this, and it's not funny, but ours is the only profession where the rate of suicide is going up, but people still think we can help them, which is sad. If you look at it, psychiatry there is a shortage of psychiatrists, and the field is there, but we have not been able to do much about the increasing rate of suicide. I think the causes are multiple, but the social fabric being affected, and various taboos being broken over the course of last 50 years plays a huge role. And now you introduce social media to that. And I remember the video games coming back when 74, I went to Niagara Falls and me and my friend played ping pong with this little machine where you put in a quarter and you play ping pong. And then came all the violent games. And somehow a person dying during the game was just not a big deal because you come back and you do it again. Or you fall off the ledge and you do it again. So that mentality has somehow permeated in our thinking. But the social isolation, lack of support, it's very sad to see, 3 people at the dining table all with their iPhone watching the phone while waiting for food. But that's what our world has come to, and it doesn't look like it's going to get any better. I know of cases where social media posts played a big role in somebody wanting to kill themselves or doing it successfully. So it's very sad.
For those that are listening, there is a suicide crisis hotline, and it's 988. I've never used it myself. I feel like I should try it and make sure that it works if we give it out to anyone. And I don't know how successful they are in helping those, but if there is a family member struggling, and to give an idea how to get into a psychiatrist, or in rural America, it's a MD or a nurse practitioner. How do you stop the idea of, if I go to a psychiatrist, I'm crazy, and everyone will know, and it's the stigma associated with it? Or if a parent knows that they have a teenager that is vulnerable or talking about it, what do people do? I mean, because I've chosen to live in Dallas now, I have access to a whole referral source of phenomenal, so that if you're not available, then I can go to 2 or 3 or 4, get them in. I know how to navigate these very complex systems. But what is a family to do? And then I want to talk a little bit about the intake process. If somebody gets into a psychiatrist, what can they expect? And you can talk about your own practice or in general, but I know those are many questions, but I just think through families, like, we're so scared to take action for fear of what people are going to think.
Well, there are a variety of reasons, and this is sometimes a source of frustration. So one area that's positive in last 40 years that I've seen a change, 35 years, is schools are being very sensitive to this issue, and kids don't mind telling somebody that so-and-so is thinking of suicide. And the school counselors have often done a fantastic job of identifying a problem and making parents aware of what's going on. So that's one positive. So where do you reach out? And this becomes a challenge. And city to city and county to county in Texas, what the law will do is extremely unpredictable and often unprofessional. So I've had situations where the patient's in the ER and person from the law that came to see them would say, he had a gun, but I didn't see him actually putting it in his mouth, so I can't commit him. That's how crazy it's gotten at times. Other side is that certain local police departments are very sensitive, and if there is any doubt in their mind, they'll take the person for an assessment and hold them for a period of time. Now, for people who are having problems that require any kind of psychiatric, mental health related help, the resources are there. if nothing else, start with your clergy. I know some excellent ministers that are very astute at recognizing the need for help and motivating the family to create that help. But what happens is often the person that's trying to help has limited resources, and they're exhausted by the time this situation it keeps deteriorating. So you have a family member that's non-functional, has been a problem for a long time in your life, and at some point you say, I can't, last time 2 times or 3 times I took them for some kind of an assessment, nothing happened. Mm-hmm. The hospital stays have shortened because of the way our system is. And people don't have the resources. So I would say anything from finding a therapist, interventionist, and if they don't go, you go. One of the things I tell patients sometimes is, if you're having a problem with one of your family members, you can tell them that I've gone to see a psychiatrist, and it's basically because I'm struggling with what you're doing, and I'm trying to get some help. Now, often that will lead the future patient to say, well, there's nothing wrong with me. Maybe I can go talk to the doctor. And then they do come, or they'll go somewhere else for help. But letting the other person know that you're so disturbed by what they're doing is that you are seeking some help for yourself, because this is driving you to insanity. But sitting aside passively does not work. And even with all the efforts, services are limited, and often people don't get the help they need.
I agree with you that it's really difficult to find qualified people that are available. And then also the system itself, everybody has all these initials behind their name. Some are licenses, which means that you had to do academic training, a practicum, an internship to make sure that you know what you're doing. And some are just a certification that you can then add to if you're already licensed. But certifications, you can go to a weekend class and become certified in something. It doesn't mean that you're qualified to treat. And because I think of some of the initials, like people, when you say you're a doctor, we've had some doctors on television that are not currently licensed, that people don't know what is the difference between a psychologist and a psychiatrist. So answer that first. What is the difference between a psychologist, which call themselves doctors as well because they have PhDs, and someone who is a medical doctor who actually is a psychiatrist?
So, as I mentioned before, a psychiatrist has gone through years of training in a residency program. They worked in an inpatient unit, they worked in outpatient, various settings. They are familiar with more interventional treatments, including medication. Psychologists have a very long ramp for training, and their training requires them to do a thesis of some sort, plus they do therapy. They learn testing that psychiatrists, we don't do. So for psychological testing, neuropsychological testing, and for therapy, they work very well. Then you get counselors, and the counselors typically have a master's level degree. Some of them are, I used to teach at SMU at one time, and the very first thing I said to the class was, your grades don't matter. Really, that makes no difference whether you're an A or a C. What's going to matter is, do you know the local resources? Do you have a social network where a patient needs a doctor or a testing or anything else? Are you going to be able to provide that with a successful team of people? And where you trained is very important. If you trained in a outpatient clinic somewhere where they only treated one thing, then you're probably going to have issues down the road. So the variety of training you get makes all the difference. Then you got the people with drug and alcohol counseling background, and they are generally better than anybody else at recognizing addiction because that's what they do. And many of them were going through their own struggles with addiction. And so they understand that behavior well. But the bottom line is you got to have a team of people depending on what's needed at a given time. Then you got nurse practitioners, and there are nurses that went and got training with all of these. My concern is that often they have gone to some for-profit university that takes no in-person classes. Then they train under other people with the same degree that they have, where they're not really getting the exposure. Many of the providers that do medical treatment, such as the nurse practitioners, have never set a foot in a psychiatric facility and don't really know what an acute patient looks like till the day they go in the practice. So that creates a problem. In that regard, I think proper psychiatric training gives you the exposure to things that you don't get exposed to in other educational situations. I know this is somewhat of a controversial statement, but this is the reality. That this happens is that a nurse practitioner that went through training has never really worked with a psychiatrist. They went to some nurse practitioner's practice to learn, and that I think is not enough. Now, many of them do very well afterwards because they'll get into a job where they take the challenge and learn more. And as a doctor, what I have to know is this is a learning process. Even today, I'm learning new things. You really have to be open to learning new things.
New diagnosis, new drugs are out there. As soon as they get rid of one thing, something else is on the market. There's a new form of opioid that's being sold on the counter at all the convenience stores and grocery stores, and people don't know it has opioid-like results from it and become quickly addicted. It is so dangerous for this young population because once they leave the home of the parents, they are in the home of the school and all of the environment. And I think schools and teachers do the best they can, but there's no way they can manage and monitor and what is going on and how to help and how to control. Not bringing substances. That's been happening years and years and years. Bringing substances in and then looking for those vulnerable ones that are just willing to try it.
So the new substances, the new opioids, for example, synthetic marijuana, to all the new drugs that are coming out on the streets, often we find out about it from our patients.
Yes.
Or from a newspaper article. Before the professionals get hold of it, that information is often we learn from our patients. So that sort of learning is also important because they'll tell you what's going on.
Well, like in Fort Worth last night on the news, there was an accident in Fort Worth and a van was hit. Both people in the van died, and they discovered $3 million worth of liquid meth. And the police officer that was accessing it had to go to the hospital. He's going to do okay. But it was like, wow, this is everywhere. And it's one of those easy available drugs, and people become dependent on it within the first use often because of the way it changes the brain chemistry, the neural pathways, and the functionability. But that first dose can also be lethal.
Yes, so that's the only dose they ever tried, just one time and they're done.
One time and done. What do you say is the answer to this chronic shortage of psychiatrists in the United States?
It's here to stay because most of us, it's not a surprise that you're interviewing somebody who is on Social Security because not enough training slots are available. So a large number of psychiatrists are above age 55 in this country. And I heard that about 5-7 years ago, so there's no telling where we are right now. This is an issue. I think this is where properly trained other professionals working in a team would be very helpful. But it's a real problem. We just don't have enough trained people in this country. Well, take a place like India. There probably, if you go to a big city, you may have 20 good psychiatrists, and there are 1 million people there.
Which, do the math, 10 million divided by 20.
There'd be 1 million people with 20 psychiatrists. And it's just, there's a shortage. Mm-hmm. And family practitioners, nurse practitioners, and others take over the medical side of treatment as best as they can. But this is a problem that we're going to have for a while. The good news is there are a lot of new advances coming, and that's pretty exciting. Mm-hmm. On the medication side, other treatments such as transmagnetic stimulation, esketamine, there's this whole field of psychedelics, but I'm sorry to say, but the research is pretty murky. I think that this is an area that we have to really be careful before we just jump into it with both feet. Mm-hmm. But people are doing it.
So let's talk about if a patient, because I think if you take away the fear, first of all, I just want to talk about your office because here we are at Lakeside Life Center. And this is where you've practiced for many, many years. And you have not just you, but a whole team of professionals and an amazing reception or office manager, Lynn, who helps take care of and figure out solutions. So if I make a phone call and I have a family member and we don't know each other, let's just talk about the general public, and they know that they have a family member, because now the statistics tell us 1 out of 5 people are going to experience some type of mental illness in their lifetime. 1 out of 5. From the first call, and we're a good fit for you, what happens in that process?
So there are some things we don't do. I guess I'm somewhat old-fashioned, if you want to say that. But we have a phone that's answered 8:30 to 5. Now, sometimes things happen and we don't answer the phone, but 99% of the time, we're going to answer the phone with a live person. The people who answer that call have all worked with me for many, many years. My office manager is the key, who plays a key role in that. And at that point, we have to decide, is this something that's urgent? Is this something we can even treat? There is the financial issue, because I don't take any insurance, but other providers in my practice do. So often, if they're not available, we may have to refer these patients out or figure out a way to help them. The other thing we have done is, hopefully we've kept things pretty personal. So if you walk into my office, it feels like the living room of a home, as does my personal office. And that was a brilliant stroke by somebody I know that helped me design the office. And that person happens to be a coach and a person that used to be in the counseling profession. And I think that's really paid off. Patients appreciate that if they walk in here, they're going to be in a reasonably calm environment. A lot has changed with telehealth, for the better and worse. I think more people are reaching out for help. But sometimes you really have to see the person in person. And that's what I have, is a hybrid practice. We have full staff. If you need to be seen, we will insist that you do. And I do part-time telehealth, but my preference would be in person, especially with new patients. We do not like to see new patients online and not see them again, unless there is an exception, which is if they are in a facility, then that's fine, because there is a whole bunch of collateral information we're going to get. and there is a other set of eyeballs looking at the patient. But I think that one thing that I find extremely shocking is I may have seen a patient that come 2 years later, and there's no on video camera you could tell that they're limping, or they've gained a lot of weight, or they look a little bit more disheveled, their clothes are not as clean as they used to be, or they look better. So those are the kind of clues that you miss. So telehealth is good, and if it's the only option that's available, then that's the only option that's available. But I also think that periodic in-person visits are good. Now, that is not to say there aren't therapists that do a fantastic job of doing telehealth. And I know one person that they practice out of Idaho or someplace, do excellent clinical work with doing dialectic behavior therapy. And I'd feel very comfortable referring to them because they have a very strong working relationship with the patient. So ultimately, even if you don't agree on everything, if you have a working relationship with your patient, where you're not just filling out a prescription, but when something goes wrong, you get together. I guess in the old days, they used to call it therapeutic alliance. And that's true about anything, whether it's for cardiac health or psychiatry, is if one party is not doing what they need to do, then that needs to be examined. And I will often tell my patients, it looks like I'm working harder than you are to get well. So what are we going to do about this? Let's solve this problem.
Yes. I've also experienced you firing patients if they are not going to take their medication or adhere to the things that will help them.
It's
and
not,
I know it's rare.
I think firing is the wrong term. Actually, I've taken people back that I said I won't see you because they came around and said, and this is something that, malpractice people say, don't ever do it. But sometimes people change for the better. So you have to have that hope. And sometimes you have to say, look, you're not ready. And I remember an adolescent psychiatrist in Fort Worth, very well-respected gentleman, this 16-year-old, he said, look, you're not ready. I'm not going to fire you. You can come back anytime after you quit drinking or you do something about your drinking. Till then, I can't help you. Then there are people who simply violate rules or really have no boundaries. And sometimes you have to say, look, it's really not a workable situation. But the number of people we actually refuse to see out of what we have is exceptionally low. What is more common and problematic is people just leave the practice. They don't show up. And next thing you know, they've gone off all their medications and they're back 2 years later because they have some problems or some really bad things happen to them.
Yes, I think I used the wrong term, but I like that you hold all of your patients accountable and you have a high expectation of what you expect of them. You expect them and you want them to get well, but I think you have a phenomenal way to build a relationship in a very non-intimidating way from the very beginning when you first start meeting with the client.
Yeah, and we talk about therapeutic neutrality and not saying something that expresses your opinion, but I don't necessarily always think it's correct. If somebody's drinking and driving and you don't tell them, you got to do something about this, you're really not fulfilling your role. You can't stop them, but certainly this is something you could take seriously. The other issue we often face is that there is a difference between confidentiality and secrecy. Mm-hmm. So getting the family involved in treatment, especially when somebody has severe depression or bipolar disorder, schizophrenia, substance use, you may not tell them everything that's going on, but them being aware that the person's, getting feedback from them. Because I could be sitting here and somebody could be telling me a story. How am I going to know if it's true or not? Mm-hmm. But having collaborative information from family helps. And often patients will resist that, and often they won't. But having them all in the room, and that's why the highest number of people I ever saw out of a family was 9 people.
Wow.
And they all were there complaining about this person, and he wanted to run away to Colorado for obvious reasons. But so that's very important to have awareness of what's really going on outside that, because the traditional psychotherapy came here from the concept that Freud had, which is you get on the boat, you go to the island where he practiced, and you talk to him, and you go home. And that there was no such thing as involvement of the family or collateral sources or anything else. But as the field of community psychiatry developed in the 60s and 70s, and family therapists came out with the family systems theories, that all has changed. Now, you may not practice family therapy as in a traditional family systems way, but at least get the data. The one area that in my field, the biggest complaint I have is not looking at the data. And I'll give you 3 examples. Luckily, I have the luxury of knowing these people for a long time. So we had 2 clients recently. One, I looked at the paper records going back to 2012, because this person's not doing well now. For last year, they have been really not doing well at all. So what went wrong? I mean, I could throw 5 different medicines at them, but what was working back then that is not working now? And I'm not going to remember everything. Interestingly, as I looked at it, 2 things came out that were just absolutely outstanding. One was that they'd taken a medication called an MAO inhibitor that's, I'm not even sure if it's available anymore. It's called Aldepril. And they'd done well, and they'd done well on a particular antidepressant that used to be a brand at that time. It was not a generic. And when I tried the generic, it didn't work. So now I got to work on procuring the brand name drug, hoping it'll work. Second patient was somebody that I had, the family member was in the mental health profession. I got a call saying they're in treatment facility in Florida, and they're like psychotic. Well, I knew better. I'd seen this person doing really, really well. And I did my digging, and it turns out that somebody in their wisdom decided to take them off their T3, triiodothyronine, Cytomel, and things got worse. So put her back on it. They're still on it, having a very successful career, and it's very clear you cannot get off of this, and it's not a psychiatric drug. So you really have to dig. The third one just happened this last week. Things are not going well, and I had forgotten how long I've seen this person, honestly. So tried to flip through. Back in the old days, it was easy. You can flip through the chart, and it comes to you right there as you look at the pages in your notes. Well, we don't have that luxury anymore. We have the electronic records. And went back and back and back all the way, and somebody in their wisdom had taken her off her thyroid medicine. On top of that, we looked at some things that had actually worked for them before, but they didn't want to take it because that's the mood they were in at that time. So we went back to that. So sometimes you have to backtrack, and it's not easy. Like, give you an example, a professional, an attorney, was non-functional, not doing well, and they were, again, you took history. That's why you talk to them for an hour. It's like, when was the last time you did okay? Well, I was okay in 2002. Again, same thing. They were on sertraline, which was a brand at that time, Zoloft. And guess what? Put them on branded Zoloft. They're doing great. Now, irony is that some of these meds are not available, or they're outrageously expensive in this country. So they get it from abroad. And I don't have a problem with that because it saves lives. The biggest frustration is that you decide you need to do something for this. And I don't see people who are on their first rodeo. They're not on the first medicine. And you want to give them something different. And you're dealing with somebody in an insurance company that will send you a letter. You have to do a request. and they don't have a clue what you're dealing with. And when you do finally get a denial and you want to talk to a doctor, you get another letter saying, oh, it was denied by this doctor. What did they do? Oh, he's a pediatrician. Well, what would he know about psychiatric treatment?
Right.
Or emergency room doctor? I'm sorry, they're very good doctors, but they don't know why this is being done. Mm-hmm. And often fighting for those people is hard because the way the system is rigged is we don't have the resources as doctors. We do not have the resources. So their goal is to tire us out by having to do all these pre-authorizations. And I have a field day with that, absolute field day. I just love doing it because, and you know, I think ProPublica is doing some work on that. They approached me a couple of times, but you know, who has time to go talk to media about this? But this is a major issue in psychiatry right now, and I think it's being swept under the rug, and insurance companies are basically getting away with it. There's no other way to put it.
Right. So when a patient comes to see you, they make the phone call, they come into a comfortable lobby, comfortable office that would be similar to their own living room. And then you go through this process, getting collateral information from family members, meeting with the person, doing an assessment, collecting a lot of information. And then what is the determining factor from medication versus just psychotherapy or some type of therapy? Do you know that instantaneously? Like, what, or is it the severity, or how do you make those determinations?
It's a work in progress.
Okay.
And it's a work in progress in 2 ways, or 3 ways. You know, what is the person willing to do? How far they're willing to go? What resources they have? Both financial and emotional. And then, what do you think you can start and get some quick help? So if it's somebody who just witnessed a murder, it's really important you get them with someone who does EMDR work. And this happened to me recently. You can give them medication, but you know they really need to get that taken care of. Mm-hmm. Or somebody who's chronically non-compliant, but had done well on meds, you work on compliance. And this whole idea that people should be independent and they should take their medicine on their own, I think is great in theory. But some of our more severely ill patients don't or won't, and they need help with it. Mm-hmm. But the way I see it is it's a work in progress, and I think that's something that I don't ever tell patients as such, but I think they know that this is like our first salvo. And I give example of the first 2 plays of a football game. You won the toss, you decided to, field the ball, and the other team has the ball. Well, you're going to try different formations or what have you to see what works. If you're offense, you do the same thing. You try to run the ball, you see something that may not be right, and you kind of attack that. This is no different. It's like the first quarter of a football game, except it goes on till the patient gets well.
Are you a football fan? I'm curious.
I love football.
Do you?
Love watching football.
All right.
I had a football player as an intern at one time.
Oh.
And it was the most fascinating thing because he told me stories. And then I go to see a game where I think it was the championship game where Jimmy Johnson was the coach and Troy got hurt and he had a concussion. And you could tell sitting where I was that Jimmy was in complete control of this team. You could tell from his body language and body language of players that came near him. And it was quite a sight. And this is around the time when I had that intern who was a football player. And it was sort of a funny scene. I'm like, 5'4", and he's 6'5", and we would walk in the hospital together.
Wow. So to recap, when a patient comes, it is to see what they're willing to do, to see what type of support they have, both physically, mentally, emotionally, even spiritually. And then the third was it's progressive. To be able to, not progressive, it's a process. to help them get to a higher level of wellness. And then if they need something more, you have resources to be able to help them get, if they need to be in an inpatient facility, or if they need psychiatric stabilization. There's a lot of programs in the Dallas-Fort Worth area where they can go for a week or 2 weeks. Usually it's short term, in order to get on meds so that they have staff that can recognize if it's working, if it's not working, make sure that they do take their meds or motivate them to take their meds, and then to get them to a safety plan, a safe place, so that then family members can help support them when they get out. And then often it's followed with intensive outpatient. They're going to have a psychiatrist assigned to them, either the one that took care of them in the program.
Correct.
They have a private practice. And then the process is, it is a longer term. It's not a quick fix. Is that right?
I don't think there are too many quick fixes in our field. But any kind of behavioral medicine, whether it's diabetes, there's no quick fix. You have to change your lifestyle. Well, that's a long process in diabetes. Mm-hmm. So yes, you're correct.
So, Dr. Vasavada, what wakes you up in the middle of the night around 3 or 4 a.m.?
Not a whole lot, because I really have a spiritual belief about it, is that, I do the best I can. Once in a while, if I forgot to do something, I would.
Yes.
But, and it happens, but now I just do it in the morning. And not a whole lot, but if somebody was going to hurt somebody else, that would keep me up.
Mm-hmm. Well, that's good. That says that you must have a lot of self-care or have created an environment of support for yourself or essential care. What are some things that you do as a mental health professional to take care of yourself? What brings you joy?
Great question. I think one is that for me personally, the biggest thing I have is a social network and taking time off. Actually just unplugging completely and be gone. And typically I'll go out of the country, and I have a wonderful group of people, Dr. Tay Lee, who is my partner for the last 15 years, something like that, or longer. He's wonderful. So we take turns in those situations. So taking time off and unplugging, spending time with the family, I think is very helpful. Social time where you actually meet friends and spend time with friends. I'm not big on physical exercise, but I do some. I'll go on and off the ramp many times. But when I do, it's very helpful. Mm-hmm. So I think that in any profession, if you're feeling the burnout, it's really important to change the pace for a period of time.
What does burnout feel like?
Well, it's a feeling where you're feeling tense. You sometimes don't like your work. You become very irritable. You see only problems at your work. Your behavior changes because of your work.
Yep, I would agree with that. And you seem very content and very happy with who you are and where you are and what you're currently doing.
Yeah, I think that at this point in my career, I've done this long enough, and if I don't have the compassion, and I tell patients this sometimes, it's like suddenly somebody starts doing very well, and it'll slip out of my mouth is that, this is the reason I want to come back to work every day, is to hear this. Young lady just Friday morning, yesterday, she comes in, she's doing much better after 2 years of treatment somewhere else, which can happen to anybody. I'm sure that's happened to my patients too when they go to somebody else. And there's a nice note from the mother saying she's doing very well, and it's the best she has been. So that means a lot, but that creates passion for me. And I don't think, if you don't have passion at this point in this work, you shouldn't do it. I was talking to a psychiatrist friend of mine about, something administrative. And he's like, okay, I got a few minutes because I'm about to go for cataract surgery. And I said, oh my goodness, that's okay. I don't need to talk to you that. He says, no, I got a few minutes. So he could compartmentalize so well that he would take that call, and then he's going to be under anesthesia. He won't even remember the call, most likely. And maybe he will. But the point is that making compartments like that. So if I'm on vacation and if I get a call and I'm in some other country, from my office, I'll take that call. I'll take care of whatever it is and go back to what I'm doing. And that's how I've conditioned myself.
So what does a vacation look like for you?
I'm always out of the country, going somewhere, pretty much always. Going to some country and traveling, start in the morning and come back in the evening and see different places.
Do you do all the planning yourself, or do you go with a company?
I've done both.
Okay. Which is your favorite way to do?
It's really depends on where I'm going, but I like, in at least more than 50% of the time, I like somebody else to take care of it. So I do. But nowadays with the AI and all, it's so easy to plan an itinerary. It's just a piece of cake.
What advice would you give to your younger self who is just starting medical school?
I think that you are in this for a long haul. And people start with this idea that I want to do what I'm passionate about or whatever I like. And I read somewhere in Wall Street Journal one time, and it was a very good, because that's exactly what I did. I didn't realize that I was doing this, but that's good. Do some of that, but do where there is the biggest opportunity to make a change. Because if you can take that opportunity and make a change, however unpleasant that job was, you come ahead of the line. So if I were doing this again, and I don't do any inpatient practice right now, and I wouldn't like inpatient practice, I would force myself to join a hospital somewhere and practice inpatient for a while. Several reasons. One is you'll see challenging patients, you'll have a steady flow of patients, and you'll get known very quickly if you're doing decent work as being good at what you do, and you can have a full practice. And one of my colleagues used to say this. He said, in the beginning, don't say no to anything. Just treat anything you can, as long as it's within your capacity. And if you don't, then learn something. And the last but not the least is never stop learning. Because if you stop learning, your patients are going to be hurt.
Is there any book that you would recommend for people out there who just want to safeguard their mental health, their mental wellness, or recommendations?
Unfortunately, no. I'm not big on that, so I can't say that I could give you a name.
Okay. So if you were going to say, give them one activity to do, let's go for emotional well-being, what would that be?
To the patients?
To anybody listening.
I think I'd probably say physical activity.
Okay. For spiritual growth.
That's an entirely different ballgame, and it's interesting you're bringing it up, because I think one of the areas where psychiatry often doesn't pay attention is where people are spiritually. Now, not that I'm a pastor or nothing like that, but there's a group of patients especially that are angry at God for one reason or other. And those people really struggle or are turned off by God, are anti-traditional religion, and they need help. So early on when I started, I developed friendship with Brother Ben. Ben Smith is the name of the pastor at Lakeland Baptist Church. And we two couldn't be more unlike each other. But he's a lovely gentleman. And I used to ask my patients, go see Ben. He'll see you for free, and he'll give you some counsel. And I was in Little Louisville, and he was very well known, and people went and saw him. But you really have to do that. So I'll probably give you the most comical situation I ever dealt with was this person calls me and said they needed to go to a confession. And I was new to Texas, so religion was not that big a deal in New York where I was. I said, wait a minute, you're not Catholic. Don't you go to a Baptist church? And they said, yes. I said, so why would you want to go for confession? You don't even believe in it. And the answer was something like, Dr. Vasavada, when you've really sinned, you want to go to a confession. So I call up St. Philip's Church, like a good social worker. And this is something you have to do sometimes, have resources.
Yes.
And I said, hey, I got this rather peculiar request. What do I do? And this is, send them over. That happens all the time. It's something they don't want to share with their... So keeping secrets makes you sicker. Shame makes you sicker.
Yes.
So I think that if it was a book, it would be Healing the Shame That Binds You. It's a very good book. So this is an area where this person was able to express themselves. And then I came across David Dickerson. He passed away. He worked with me, and he was a Christian counselor, very nice person, greatest therapist I ever worked with. He was in the military. I said, he said, Doc, that's very common. I'm Baptist, but if the Catholic chaplain is on vacation, what do we do? So I took confessions. That's the flexibility we need, I guess.
I guess so. So I'll start, bless me, Father, for I have sinned. My last confession was, and I hear you. With all of those, so if someone is struggling, what I heard you say in just recapping some of the fabulous information you've given us was to reach out to someone. Don't be afraid. And if you don't have mental health resources, counselors, primary care physicians, nurse practitioners, anybody that you could go to, and they have an ethical requirement to keep it confidential. Even if it's a small town, they do not have a right to share that with anyone else. And if not, go to someone in the clergy that you can talk to and tell them what's going on, and then they have resources, a network of referrals in order to get you help. The thing to not do is not to do anything.
Yes, and if you look at these cases of somebody taking a gun and shooting up a place, there are clear warning signs. It's just that we ignore them. It's like, he was a little isolated and he said a few bad things on the internet. Well, that's serious. When you start talking on Facebook about a group of if you're oozing that hatred or that sadness, something's got to be done. Now, we live in a country where the laws are such that you can't do much, but if there's a way to get those people out of their isolated state, it goes a long way. And I've had my share of patients like that, and when you work with them, really listening to them and not judging them and not even changing anything, but let them talk is very important. But eventually, and many of them do need meds because they are either severely depressed or have some other issues, unless somebody is just a pure antisocial personality. So you really have to work with them and gain their trust, and it makes all the difference. I think I can think of 2 instances where somebody gave me their gun because they were about to either kill themselves or someone else. So there I am with that gun, not knowing what to do. And then one was a person that was going to do something to their peers. And the irony was that it was a private school, and they kind of poo-pooed the whole thing. But making sure he understood that this is not the answer. And it was difficult. And even after he went to college, he had struggled at times with what was done to him. He was being bullied. So it's really, those are the situations where you really, just developing that connection is more important than anything, because if you have a connection, then they're going to come out. I've had only a few of those, but they're pretty scary situations.
Yes. Many scary situations. Have you ever felt threatened in your practice?
There have been situations, especially inpatient work, and my very first night I was on call in emergency room in Kings County Hospital, and a patient was hearing voices, and I was doing physical exam on him, and I was near him, and he took a swipe at it. Had he gotten me, I would have broken my jaw. Luckily, I moved away, so nothing happened. But personal safety for therapy, and if you're not comfortable treating somebody, best thing to say, look, I can't do this.
So intuitive goes a long way.
Yes, it
in
does.
that.
And if you're not sure, don't take a chance. Don't engage for a longer term thinking they could change. You could change them. If you're scared of them, chances are you won't be able to work with them. Best thing is to move on and do something else.
Well, and last question, what core values do you have? Like, what are your top 2 core values that have gotten you where you are today?
I think one is the theory of karma, where there are 2 kind of karmas, right? You do things that are selfless, and then you do things where you get paid. Whatever you do it in a way that as if you're worshiping God. That's how you do it. And I believed this even when I didn't believe in God or had questions about God, is that when it comes to your duty, I like the military way of doing things in that regard, in that you have a commitment, you honor it. And your commitment is to see patients, then you honor that. Don't cut corners.
Very good. So I have to share, there was a time after we were working together for a couple years, I was at Touchstone. I'm a licensed counselor and a licensed nurse. And every once in a while, I like to just jump in and practice with the patients and get to know them and see if there's something I can do and to give the staff a break. I don't like for staff to be overworked and underpaid, because how they come and how they present themselves is going to not only affect our community, at the treatment facility, but I want to make sure that these moms and dads that are going home, or if they're going home to their wives or their furry pets or whatever it is, their loved ones, that they are energized by working with us, not depleted to where they're just barely making it. And I also want them to be able to let go, because in this field, sometimes we hear a lot of things that kind of eat at the core, and then we start looking for and thinking about solutions. So one thing that has kept me going in this field, and I am still energized, I believe that this next 10 years is going to be the best of my life, and I don't even know how it's going to evolve yet, but I feel that. And it was, and I shared this with my staff, is after a few years of working together, and if my physicians that work for our program, and I consider you one of mine, if you call, I have a special to where I see it on the phone, and then I was facilitating a group and I saw Dr. Vasavada. So I immediately asked the community to excuse me for just a minute, that one of our doctors is calling. I stepped out, said hello, and you said, "Debbie," this is my interpretation of you. Okay. He's like, "Debbie, this is Dr. Vasavada. I'm driving to work, and I just needed to tell you something. I needed to tell you that we are doing together work that is not happening anywhere in the United States. Okay, that's all. Goodbye." And I thought, oh my gosh, I just had to pause for a second. Because coming from someone of your caliber, and you have a good pulse on what's happening in this country as far as psychiatry goes and in treatment programs. And that is one of the greatest compliments I have ever received in my entire life. And I kept thinking, oh, I only wish my staff could hear this, because I'm just one component. I just get the privilege to do what I do. And I still consider it honor and a privilege to be able to see what we can do to make a positive difference in someone else's life. And so I just thank you for that.
Oh, you're welcome. I meant that. It really is true, is that what goes on there is really good quality work that many places don't do.
Yes.
We won't mention any names.
No, we won't mention any names. No. But we'll continue. And if we can somehow make a difference in the few lives that we get to work with, because every once in a while I'll go on social media like Facebook and I'll see a former client and we can't have a relationship with them. But it can come in a feed. After 2 years, you can actually be Facebook friends. But the greatest joy is to see them doing well, to be able to be living the life that they were always capable of, but just for a brief period of time, needed some assistance and needed some help, either outpatient, inpatient, counseling, whatever that is. So we're going to encourage anyone. And if there is a crisis, 911 is also there to help you, to be able to help you come in, figure out a solution, look at resources, even if it is just a local community hospital, to be able to begin that process of helping someone who is struggling. Because 1 out of 5 of us will struggle with some level of mental illness in our lifetime. And when I count the 4 or 5 of us here, any one of us could struggle at any time, and I am no longer afraid to reach out. And I hope that is for all of our listeners. And it may not be you. It may be someone that you deeply love or care about,
Sure.
Or it may be a stranger on the street. There are always ways that you can help.
And last but not the least, if you're a therapist, you better do your own work.
That is correct. Yes, and that is so important.
Well, thank you so much for inviting me. This has been a great conversation. We don't normally get to sit down and talk like this. We're always in a hurry trying to communicate about some clinical issue here and there.
Yes. Well, thank you for this. Thank you for sharing and for all the work that you've done
welcome.
in a lifetime.